Good afternoon, everyone. I want to welcome you to today's webinar on immune reactions to insects, bites, and stings with Dr. John Carlson. Before we get started, I just want to go over a few housekeeping rules. Please, everyone, mute your line. You can use the chat box to ask any questions, and we'll answer all the questions at the end of the webinar. If you have any other questions that come up, please email us at education@nola.gov. And this webinar will offer CEUs for LA sanitarians. And next, I'll have Dr. Regal, who will introduce today's speaker.
Thank you, Astacia. Thank you. Today is my pleasure to introduce our speaker, Dr. John Carlson. He's a physician and a PhD parasitologist, so we're super excited. We actually have worked together for many, many years. Dr. Carlson received his medical degree from Tulane University, as well as his PhD in parasitology at the Tulane University School of Medicine in 2004. He's board certified by the American Board of Allergy and Immunology, and he performs pediatric allergy and immunology work. And he sees patients at the Ochsner Center or the hospital in Jefferson Parish. So he's done a lot of work, very interesting. He has done his PhD work in working with anopheles, right? So I think it's really so fabulous to have someone who's so intimately, knowledgeable with the whole entomological component, and also the medical component. If if you don't follow him on Twitter, you should. He tweets all the time on a variety of different topics. So I really, recommend that you follow him. So Dr. Carlson, thank you again for being with us. We're super excited to hear from you, and I'm going to kick it over to you.
Thank you very much. And I will share my screen. Is everybody seeing the title slide?
Yes.
Yes.
Great. All right. So thank you so much for that introduction and this opportunity to chat with everybody. I get really, really excited about bite and sting reactions. Actually, my entomology degree was in entomology as well. And it was all the way back then that we would get these really interesting stories of people being bitten by things and stung by things. And then all through medical school, even though that wasn't initially the area of my research, I just loved hearing about these crazy cases. I loved corresponding with other physicians and entomologists really around the world to get feedback on cases that I was seeing, and then to get their stories as well. So I sort of accrued this expertise over time just because of this as sort of a clinical interest. I do some research in venom reactions and mosquito bite reactions as well, but this is really just a clinical passion, and I really enjoy it when people send me in questions and photographs and samples and things like that, because I continue to learn. So the background of this photo is just different stories that I've gotten along the way. And sometimes people say, well, can you talk to me about how you sort out when somebody's been bitten or stung by something? How do you figure out what it was? And it is kind of fun to try to figure that out. So I've kind of put down my process for figuring out what bit or stung somebody based on the type of inflammation and other clues that we'll have along the way. It's not only fun, but also can be useful in determining what kind of treatment you should use, and obviously trying to prevent the bites and stings in the future. So just a really brief, quick outline on inflammation. There are more than 5 kinds of inflammation, but these are the most common 5 kinds of inflammation that we see in patients. And so I'm going to briefly go over 4 of those, neglecting the middle of those that you get with viral infections. But the other 4 that frequently present to me in my clinic or through consultations that people send my way, these are the questions I try to get to the bottom of. So first, a story of innate inflammation. So these wolf spiders, 2 different subspecies. A spider enthusiast, Jeff Hollenbeck, was taking a photograph of the 2 different subspecies for a colleague, and was in a hurry. So he was a little bit careless in getting them together, and a little bit careless getting them back into their containers after the photograph. And one of them bit him. And you can see these two puncture marks. One is weepy and wet. The other is a little drier, but you can see those puncture marks. And then just kind of zooming out a little bit, that's his pinky finger right there. That's kind of swollen. If anything, it's a bit larger than the finger next to it. And you can see it's really swollen, so much so that it's cutting off the circulation. The capillary beds are compressed, which is why you get those pale marks in there. There is vasodilatation. The blood vessels are open as part of swelling, but as they open, they release so much fluid into the tissue itself that it squishes those blood vessels back down. And the skin gets very tight and it becomes very painful and uncomfortable. So this is innate inflammation. It wouldn't be terribly different than, let's say, he stapled his finger. You would get a similar amount of swelling and injury, maybe a little bit worse because of the components of the venom are actually, they do some tissue damage more than a staple would. So it isn't just mechanical, but it's primarily mechanical, this innate inflammation. Let me contrast that really quickly with the consultation they get once or twice a year about outbreaks of spider bites. And the traditional story would be that a family is experiencing an outbreak of spider bites. And if you ask them about the pain is getting progressively worse over a couple of days. There's no witnessed bite that happens. They just notice these painful marks. They do look around after they suspect that it might be spiders. They start looking around, and of course they find spiders because spiders are ubiquitous in the environment, and so they begin to blame the spiders. I've also been referred cases where it is the physician that looks at a wound like this and says, "Oh, it looks like there's 2 puncture marks. That's probably a spider." But I think if you compare from the previous story I told you, this looks very different from that. This is different from that sort of innate inflammation. And this is actually a kind of bacteria that we call MRSA, or MRSA, methicillin-resistant Staphylococcus aureus, that is a ubiquitous bacteria that lives on most of us at this point. It does have the ability to penetrate intact skin, but usually there's some mild abrasion that'll make the skin a little bit easier for the bacteria to get through. And then this is the immune response to the bacteria. There's a pocket of pus under here that happens to be coming through in 2 separate spaces, making it look like there's 2 separate lesions, but in fact, that's one lesion. And this was a misdiagnosis of a spider bite that I see very, very often. And so in differentiating between the innate inflammation from spider bites and bacterial inflammation, which is this Th17 cell inflammation, is they're both painful. But the innate inflammation, like Jeff's spider bite, it got better over the course of days. About a week later, if he pressed on it, he could still get a little bit of a sensation of pain, but he had to really press on it after a week. There was a little purpley bump that was still left over there, but the whole point was that it was getting better on its own. In contrast, bacteria that cause this Th17 type inflammation, the pain doesn't come suddenly like the innate inflammation when Jeff knew he had gotten bitten. Immediately it hurt him. Instead, there's no obvious precipitating event for these bacterial infections, and they slowly get worse and worse and worse until ultimately you open up that wound and the pus comes out, relieving the pressure. But in this case, these bacteria have mechanisms for evading these Th17 cells, which is why you need so many of them, so many neutrophils involved trying to kill the bacteria. But the bacteria have ways of evading those immune responses, which is why it isn't getting better on its own. So those are 2 characteristics, both painful, for helping to determine the real spider bite from the not real spider bite in terms of inflammation. I know that the subject that I was put on the title was insect bite and sting reactions. And of course, spiders are not insects, nor are bacteria, but these are cases that frequently come to my attention. Bringing it to the insects, there are a variety of insects that seem to bite unprovoked. And the number of cases, the fascinating cases I have, ichneumon wasp and corsair bugs is really quite extraordinary. Ichneumon wasp, the most interesting ichneumon wasp will have really, really, really long ovipositors that couldn't possibly do anything to humans. But where you get these sort of mid-ranged ovipositors, They're pretty stiff. And of course, the reason why they're rigid is that these wasps are laying eggs in some substrate, for example, dead trees, and they need these really needle-like sharp ovipositors to basically drill into the wood. Some of these ichneumon wasps, if they land on a person, they will defensively, even though you didn't really do anything to warrant this, they will stab you with their ovipositor. But again, it tends to be these mid-length ovipositors that some of the ichneumon wasps have. So, for example, I had one patient that had a pierced bottom lip because the ichneumon wasp landed on her, and she probably did try and blow it away, and it said, nope, I don't think so, and it just stabbed her all the way through her bottom lip. But it was innate inflammation, and so it did hurt, but it healed up really after a few days. The pain was gone. There was a little bump, kind of like Jeff's spider bite. And by the end of the week, there was just a little dot, and ultimately it closed up and healed nicely. Corsair bugs, they aren't the most elegant flyers around, and as they're flying to lights at night, sometimes they will land on people. And again, even with no provocation, you're not trying to wipe it off your shoulder where it landed. They are known to occasionally take their little proboscis and just stab you with it, and it really hurts. It's a puncture wound. But there's no bacteria involved, and so again, innate inflammation, it hurts, it's startling to people, but the wounds heal over the course of a few days. Many of the true bugs will do that, along with centipedes. House centipedes have definitely, if they're on you and they especially feel threatened in any way, they will sink their chelicerae in you. Of course, if you are a centipede enthusiast, you know that those are actually modified forelegs. And in the small world of insect envenomation experts, we debate on, is that a bite or is it a sting if it's legs that introduce the venom? And I will propose to you all that we could say you got kicked by the centipede. It's sort of a spicy kick. But there are many of the insects will do bites and stings that will induce innate inflammation. Lacewing larvae, depicted here. This is actually a photograph of one that bit somebody. Lacewing larvae are these very small, very squishable, soft-bodied neuropteran larvae. Gorgeous adults, the green lacewings and the brown lacewings that'll float around at lights at night. They're really quite gorgeous. These itty bitty things with those sickle fangs, these are voracious predators, and if they find themselves on a person, they will absolutely bite you. I think that they're just, I don't know, maybe they're sensing that you are meat, and it's going to give you a go, but it's not great for them because they're so squishable. They don't last long. But so yeah, that's another of the examples with many insects that will try to bite you just by landing on you. Of course, again, this is all innate inflammation, and there are no serious health consequences from any of these. The biggest consequences we see are really the psychological ones. You feel a little bit betrayed when an insect gets on you and stabs you with its proboscis or with its ovipositor or something like that. Sometimes people really object to me and they say, no, I've definitely seen spider bites that are way worse, or quite specifically, what about the recluse spiders? Rick Vetter, who just retired from the University of California at Riverside, spent his entire career trying to figure out what was going on with the number of reported cases of brown recluse spider bites. And he found repeatedly that this is a mistake that physicians are making. So physicians start making diagnoses of spider bites without the expertise to do so. They see a wound, and it's usually MRSA, but also melanoma, many other problems, and the physicians misattribute it to spider bites because they don't have the entomological or arachnological knowledge to really understand what's going on there. So unfortunately, for your professional caution is that you will run into members of the public that will say, oh no, I know this was a spider bite that was diagnosed by a physician. Unfortunately, that is not trustworthy. That is not a way in which spider bites can be diagnosed. You can't look at a wound and know that it was a spider bite. If you go up to Arkansas and some places where brown recluses are super common, there the physicians are a little bit better. There is a sort of a classic shape and color to recluse bites. It's sort of a purple teardrop shaped wound. Again, it's mostly innate inflammation, not just from the bite, but the venom can destroy some of the tissue underneath. But it's not like these big ulcerative lesions. If you Google it online, you'll find these horrible, horrible pictures. But really, most of those photographs are not substantiated that they're actually from spiders. In the few really awful cases in which you can say, yes, it was a recluse, I strongly suspect that there was a problem with the immune system that prevented the venom from being degraded appropriately in those patients. But the vast majority of even documented recluse bites are either dry, or if venom gets in there, it's just a little purple bump. And again, it does hurt for a couple of days. After a week, it's mostly healed up. The same innate inflammation that you would see in general with other species of spiders. So getting back to our kinds of inflammation, we again are going to differentiate the innate inflammation. The pain is getting better over days, and the Th17, which is bacteria, the pain is getting worse over days. But now we want to move on to these other kinds of itch. The lesions that itch. And so the itch is characteristic for our allergic immune system, which is largely driven by a subtype of immune cells called Th2 cells, as opposed to the Th17 cells that are charged with fighting off the bacteria. The allergic immune responses are absolutely fascinating, and they're much more complicated than the immune responses to viruses or bacteria. And sometimes people say, why are there so many different immunologic tools to fighting off parasites with the allergic arm of the immune system, as opposed to the viruses and bacteria? And just as a very crude estimate, sometimes what I say is, well, just look at it. Viruses living inside of your cells, they're itty bitty tiny, and they're all itty bitty tiny. And the bacteria that live on the outside of cells, they're pretty small within a fairly narrow size range. But your allergic immune system is charged with fighting off anything from a worm, a helminth, all the way up to a tick. And if you just think about the size differences between those organisms, it's pretty astronomical, the different kinds of threats this part of the immune system is charged with protecting us against. And when that doesn't make intuitive sense, I say, well, that would be the difference between the weapons you would use to fight off a mouse attack versus fight off a whale attack. The immune system doesn't actually use different tools in fighting off mice versus whales, but I think that that's a good comparison, kind of explaining why we have so many different parts of the immune system that are engaged in allergic immune responses, which again, we called it the allergic immune system. Of course, we didn't evolve the allergic immune system for the sake of making ourselves miserable. We evolved it to fight off parasites, like the helminths, the mites, the ticks, and other multicellular organisms that are trying to make use of us. All right, so getting into these Th2 cells, here is a classic story that I will get. People will either come to my clinic here, or I'll get a consult virtually from elsewhere in the country or around the world. And this is just sort of a classic story. Would be, the family is really concerned because the little girl, pictured here with her foot, is getting these itchy bumps, often on the lower extremities, sometimes elsewhere, and it tends to be clusters of lesions. Like those Th17 responses, it's itchy, not painful, but similar to the Th17 responses, the itch gets worse over days. And it's hard to pinpoint exactly when the itch started, in the same way that for the bacterial infections, it was hard to pinpoint exactly when the pain started. Now, oftentimes this will be, the kiddo gets picked up from daycare or school on a Monday, and so they see that the bumps are all over them. They say, when did this happen? Of course, because it came on so gradually, the people at daycare or school say, well, we don't really know. I mean, we really couldn't pinpoint the time. They do a search of the schoolyard or the nap area, and usually they'll find spiders. They'll wonder if it was the spiders. Sometimes they'll find little flies or other organisms, tiny beetles, and they'll wonder, is the beetle, the storage beetles or other things, are these the cause of the child's lesions? Interestingly, they'll often have tried antihistamines, and they will report that they did not work. And so they come to me and I apply, again, my knowledge of the immune system. And so I'll tell you the story that goes on in my head and in the child's body is you get a mosquito bite, which is often the cause of these types of reactions. And the saliva is injected into the tissue. In the tissue, you have these cells, dendritic cells and macrophages, that are charged. They have other jobs, but their main, for the relevance of this story, the main concern is that they have danger sensors. They're looking for substances that should not be there. And these danger sensor molecules on the surface of these cells will pick up that, okay, we've got something going on here. And then one of those cells, the dendritic cell, when it becomes alarmed, it is charged with picking up the material from this extracellular environment in the tissues. And so in this case, it's picking up bits of mosquito saliva, and it carries that into the lymph nodes. And in the lymph nodes, it finds these Th2 cells, and it begins to show these Th2 cells, this is mosquito saliva. It'll show other things from the tissue as well, but those will be proteins that are supposed to be in the tissue. And so no T cells will activate against them. But in contrast, the mosquito saliva is not supposed to be there. And so these T2 cells will recognize it and say, aha, that's mosquito saliva. The Th2 cells that recognize the mosquito saliva do a clonal proliferation. They'll start off with one cell out of a billion, but as they replicate, suddenly you have thousands and thousands of these cells that now specifically recognize mosquito salivary antigen. The cells will go through the bloodstream and from the bloodstream into the tissues. Now, they'll go into all of your tissues. In order to know that it's in the right spot, the spot that the mosquito injected the saliva into, it'll look for the mosquito saliva being presented this time by the macrophages. So macrophages and dendritic cells are very similar. The big difference being that the dendritic cells moved to activate the T cells for the first time in the lymph nodes, whereas the macrophages stayed in the tissue to be able to reactivate the T cell that are specific for the mosquito saliva when it got into the tissue. And so once it sees this cognate antigen, the mosquito saliva, for the second time, the T cell becomes very, very active, begins making a lot of different cytokines, inducing the Th2 type of inflammation, which includes a tremendous amount of itch. Incidentally, it will pull in a partner cell from the bone marrow called an eosinophil, which will also move from the blood, from the bone marrow through the blood into the tissue. And between the two of them, they cause all kinds of havoc, making extraordinary amounts of inflammation in the tissue. Very, very, very itchy. This story is a long one, and in my head, I think it through quickly. But in reality, it takes 24 to 48 or even 72 hours for this whole story to progress, from the moment the mosquito bites to the point where you have these thousands and thousands of T cells with their eosinophil partners in the tissue causing that inflammation. And so that's the story. That's why we call it delayed type hypersensitivity. The child was not bitten at daycare. They were bitten the day before, maybe a Sunday picnic, or maybe the Saturday night. And from the inoculation with the mosquito saliva, it simply took that long before the T cells were in there seeing the mosquito saliva from the macrophages as a second time. They begin to activate. Now you're getting the itchy bumps. And so the poor daycare or school, they're getting blamed for the bites that actually happened over the weekend. Now, sometimes it's even murkier because it will be, it's a Tuesday night out at dusk, which is when our Aedes mosquitoes love to feast on little exposed legs. So Aedes albopictus and Aedes aegypti having their feasts, but these kids having the delayed type reactions, it'll be, maybe Thursday or Friday before the bumps are beginning to develop. So it's very, very difficult sometimes to put all of this together, because by the time the bumps are coming out, you have to go back in time and remember what was the child doing. And because it's this huge time range of 24 to 72 hours, well, the child was doing all sorts of things at different times of day, on different days of the week. And so pinning it down to the exact moment when the mosquito might have been getting them is definitely difficult. It's not just mosquitoes that will cause these kinds of reactions. The two other most common that we see here in the New Orleans area are bed bugs and chiggers. Again, the chiggers and the bed bugs will also create clusters of bites with delayed type hypersensitivity. So if you get bit by the bed bugs, then you have delayed type hypersensitivity. You may not see the reaction for a couple of days. So maybe you went for a vacation and you had a lovely time at the hotel room, and all of a sudden you get back home and it's Monday that the bites are starting. Now, hopefully you didn't bring the bed bugs home with you. You may have. You should probably check that. But it's also possible that the bites are arising, but you didn't bring them with you. It's simply taking this much time for the reactions to develop because it's delayed type hypersensitivity from these Th2 cells. One little caveat I'll just throw in there is that sometimes these bite reactions they form into full blisters. And if there's just a little bit of fluid in there, I'm not going to get overly riled up. But there are more serious conditions that can lead these insect bite reactions to become real blisters. So here's one patient with the blister on the bottom left. Those are the ones I'm most worried about. And anybody who has one of those, there's something probably wrong with the T cells. For example, a T cell lymphoma or a B cell lymphoma. These are cancers. In this patient with the blister on the bottom left, she actually had celiac disease, which is a problem with T cells. And so anybody who's getting blistering reactions, I'd love to see them or have some high-risk allergy doc that can take a look at them and just think through that maybe there's something a little bit more serious going on for that patient than just mosquito bites. All right, we want to contrast that delayed type hypersensitivity with a different kind of allergy called immediate type hypersensitivity that most adults are much more familiar with. For immediate type hypersensitivity, you've been exposed to mosquito saliva or the insect saliva of any kind in the past. And instead of T cells, it's B cells that recognize the salivary antigen, undergo clonal proliferation, just like the T cells did. And some of those B cells will become a kind of cell called plasma cell that moves into the bone marrow. And every day for decades, this plasma cell will make antibodies. In some unfortunate cases, those antibodies are the allergic antibodies. They'll float through the bloodstream into the tissue on cells that sit there called mast cells. The little granules depicted in this mast cell contain histamine, which is what causes itch, which is why you try antihistamines when you've got some itch. So those allergic antibodies are the trigger, basically, for these landmines that are sitting in every tissue in your body. Of course, that landmine isn't going to go off without the specific trigger. But if the mosquito comes, injects its saliva into your tissue right there, these IgE molecules, these allergic antibodies, will recognize those antigens, they'll cross-link and send a signal to take those granules with histamine, send them out into the tissue, and then you'll get the histamine-mediated inflammation. This is what that looks like. You can see that it's a little different from the T cell reactions. You can see that it tends to have a real pale center. There's so much swelling. The fluid is coming out so quickly from the blood vessels in response to the histamine that you see that compression of the blood vessels, kind of like the innate inflammation that you saw before. And you see this rim of red. We'll call it a wheel and flare reaction sometimes, as opposed to this kind of a beefier red in the delayed type reactions here. The architecture on the immediate type, it's kind of a sharper bump, as this is more of a dome shape architecture for the delayed type hypersensitivity. I love this photo in particular, that this was my daughter. And I saw the mosquito biting her on the left. And so I did kill the mosquito first, but then I got my camera. This was before cell phones were so common. And I took a photograph, and then I marked the time, and then I took a photograph of her foot exactly 24 hours later, because I knew that she had delayed type hypersensitivity as well as immediate type hypersensitivity to mosquitoes. And so I thought it would make a beautiful contrasting photograph. So credit to my daughter, Evangeline, for posing for this wonderful demonstration of immediate versus delayed type hypersensitivity reactions. Again, this was about 5 minutes after I killed the mosquito, and this was 24 hours after I killed the mosquito on the right. Now, it's important to note that you can have both immediate and delayed type hypersensitivity reactions in the same person, or you can just have immediate type, or you can have just delayed type, or you can have neither. And so the type of reaction you see actually doesn't tell you what it was that bit you, other than what the patterns of exposure were. So when you're born, the moment you're born, you don't have reactions to any of these bites or stings other than innate inflammation, but you won't have immediate type or delayed type reactions. And so old research papers here that I cited on so many different arthropods, bed bugs and fleas, and mosquitoes and more, show that everybody, the first time they're bitten, they have neither immediate type reactions nor delayed type reactions. And so if you see somebody who's bitten and they don't have a reaction, that suggests that they haven't had previous contact with that insect. With subsequent reactions, you'll typically get delayed type reactions without immediate type reactions. And so let's take the example of mosquitoes. Unfortunately, in New Orleans, everybody's getting bitten by mosquitoes, right? But the first time you get bitten, you have no reaction. But after you've been bitten once, twice, three times, at some point your T cells get engaged and you will only have delayed type reactions. As the mosquito encounters progress over your life, suddenly these B cells get involved. You have immediate type reactions, but you haven't lost your delayed type reaction. So for example, in my daughter, she had that immediate reaction. The reaction then subsided, but 24 hours later, it appeared to come back. So that means she was around something that was common enough that it was getting her multiple times over the course of her little life. Now, over many, many years of being bitten by the same thing, eventually you will lose your T cell responses and the delayed reactions will subside. So in the case of mosquitoes, you think about teenager years, absent somebody who's being very careful with their repellents, which I do recommend, you can expect that most people will no longer have significant delayed type reactions, and they'll have only immediate type reactions, and that'll last into an adulthood. Now, if you spend lots of time outdoors as an adult and you're just not bothered by the mosquitoes, you let them keep getting you, eventually your immediate type reactions will also subside. Again, we don't recommend that you allow yourself to have that many mosquito bites that you would lose all of these immune responses to them. But this is the natural progression for any insect saliva or venom type as well. Everybody starts off with no reaction, then gets delayed type reactions, then has immediate and delayed type reactions, then loses their delayed type, just has the immediate, and then finally gets desensitized entirely. This becomes very complicated. Let's take a case of a bed bug investigations. The bed bugs really, really are tough. So let's say you've got somebody who's been around bed bugs a lot and they're having immediate type reactions to bed bugs, but their child is presenting with delayed type reactions. Mosquitoes, likewise. So somebody will say, no, but that's not what mosquito bites look like, or that's not what bed bugs look like, or that's not what flea bites look like. Because when I get bitten by the bed bug or the flea or the mosquito, I get the immediate type reaction. And so knowing the immunology, you can try to explain it to them, but it often doesn't come across well. If you were to go back in time, that adult probably also started out with just delayed type reactions to the bites, but they progressed through these stages of sensitization to where they are now. But because the immediate type reactions were when they were kids, they simply don't remember back that far. So within a family, you can have different people at different stages of sensitizations based on the number of previous bites that they've had to that insect. Now, for reasons that aren't entirely clear, not everybody goes through these stages of sensitization. Some people can get bitten by bed bugs or mosquitoes an infinite number of times, and their cells never sensitize. They just don't develop the allergy whatsoever. And that heterogeneity adds complexity when you're trying to explain that to family members. Just to prove the point about how a first reaction won't result in immune reactions, this was a consult that I got from California. This again was early on when digital photography was becoming more and more popular, but wasn't common yet. Certainly no cell phone cameras. But an amateur macro photographer took his son out for a walk in a park, came back, noted that there was a speck on his kid's cheek, tried to wipe it off. It was really stuck in there, put his macro lens on, took a photograph of it, downloaded it, and noticed these ridges there. And so reached out, and the question was, hey, is this an insect? What's going on there? And I was like, I mean, it looks like it, but I would need to see the actual specimen. So he mailed me the specimen, and there he had plucked it off. And there you have a stick-tight flea. Now, the stick-tight fleas are known for having really large, really long proboscis that they have in their cheek. The proboscis on this one was ripped out as he took tweezers and kind of yanked it off his kid's cheek. But notably, he had the cheek was absolutely fine. There was no immune reaction there whatsoever. A little bit of innate inflammation from the tugging that came with trying to remove this tick-tight flea. But there is no such thing as knowing what a flea bite looks like. It's entirely dependent on the stages of sensitization. All right. Sometimes I get asked, like, well, okay, so let's say in an adult, you start seeing delayed type reactions as opposed to immediate type reactions. So there must be then exposed to something new. What are you thinking of? So one is if you move from place to place, there are different genera of mosquitoes, and the sensitization seems to be at the level of genus. So if you are having Culex kinkafasciatus in our parts instead of Culex pipiens, if you are sensitized to Culex kinkafasciatus or pipiens saliva, that's not cross-reactive with Aedes albopictus. So maybe somebody from the Washington, D.C. area where they really don't have as many Aedes albopictus are moving down here, and suddenly they're exposed to Aedes albopictus, Aedes aegypti, those kinds of mosquitoes. They will start from scratch with the T cell type reactions. So their reactions to Aedes will be very different from their reactions to Culex. Or very frequently, the delayed type reactions in adults come from bed bugs because not everybody's been exposed to bed bugs into adulthood. So again, they go on vacation, they're staying someplace, they start getting some bed bug bites, and they'll get T cell reactions that time. Lice, likewise, and scabies are sort of notorious for causing T cell reactions, even in the United States. Going outside of those insects that are commonly encountered or arthropods that are commonly encountered, here's a list of sort of the zoonotic ectoparasites that people will come into contact with that in my experience are not uncommon in causing T cell reactions. In New Orleans, Culicida inornata, so over the winter, again, it's a different genus of mosquitoes. And so the salivary antigens are not cross-reactive with the other types of mosquitoes that are more commonly biting, but we got plenty of Culicida over the wintertime. And so people have their windows open because the weather is a little bit cooler and they start getting these reactions. And again, these can be difficult conversations to have, to say these are mosquito bite reactions. And they say, no, I know what a mosquito bite looks like. They simply don't understand necessarily that there are different kinds of mosquitoes that have different antigens in their saliva. All right. Switching gears a little bit, this is an example of a T cell reaction. T cell reactions are complicated. It triggers the itch scratch reflex. This would be a mosquito bite reaction, and you see what's called an excoriation. So the T cell reactions, in addition to causing itching and scratching, it also causes a weakening of the structural integrity of the skin, so that when you scratch, you're more likely to carve a chunk of flesh out in the scratching process. So it's fascinating to me that that's part of the immune system's response is to cause this weakening of skin. And you can see on her arm these little pale dots. These are areas of previous excoriations that have subsequently healed. So this is all basically intentional by the immune system to try to remove an offending agent. And likewise, here's a picture of my son. He's now 18, but when he was littler, I again saw a mosquito. I bit him. I smacked my child, which I felt a little bad about. I had to explain that I wasn't trying to hit him. I was just trying to get the mosquito, but I was a little too delicate, so the mosquito flew away. But he started scratching, and I said, oh, can I take a picture of you scratching? And he said, sure. So here again, you see that immediate type reaction. So that pale dot, the pale circle surrounded by the rim of this erythema, this redness, that wheel and flare reaction that's characteristic of the histamine-mediated inflammation. But I loved the scratch reflex depicted here because it is a complex reflex. It's all a spinal, immunoneurologic reflex arc that involves the spinal cord. And so the angle of the fingernail is instinctual, and the pressure of the fingernail in the skin is regulated, where if the nail goes too deep, it hurts. And so you kind of lessen the pressure. But if you're scratching too gently, the itch remains, and so it's not satisfying. So you get this sensation of itch. And these somewhat sad studies done on dogs, you can actually sever the spinal cord. So the brain does not have to be involved in the itch scratch reflex. It is an intensely neurologically regulated process that repetitively moves the fingernail, or in the case of a dog, a claw, over the point of itch over and over and over and over again. If you then have to step back and really wonder, like, well, gosh, why would you have this really complex immune mechanism? Why would you want to loosen the structural integrity of the skin so that you'll remove a chunk of flesh from a patient? Like, that doesn't sound like a good idea. And so we have a couple of studies that sort of demonstrate some of the value of the itch scratch reflex. One was a study in 2005 performed by the group that was newly formed to study risk factors of Lyme disease back when that was really spreading over the Northeast. And they did a lot of blood tests on sort of community level blood testing and surveys of people trying to figure out what the exposure patterns were. One of their hypotheses was, since in order to have itch from tick bites, it means you've been exposed to the ticks before. And so their thought was, if you ask people, do you itch with tick bites? If they said yes, that way they would use that as a proxy measure for previous exposure to ticks. And so from that, they would gather you'd be at higher risk of having Lyme disease or having been exposed to the Borrelia spirochetes that cause Lyme disease. But they found the opposite. They found that if anything, the itch seemed to be protective of having an immune response that demonstrated prior exposure to these Borrelia bacteria. And they really didn't know what to do with that. It was just sort of a surprising finding. But I remember reading that and saying, aha, this is wonderful. This is the demonstration of the value of the itch scratch reflex. So again, there is variability. Some people really have aggressive allergic immune systems and they prime very quickly with, say, a single previous exposure. And other people, it takes a number of encounters before you're able to induce the sensitization. So people who are more likely to be the riled up allergic immune systems, they'll get this itch scratch reflex. But this is exactly it. This is how you remove ticks. I know we have like fancy forceps removals and things like that, but on the cheap, your fingernail is perfectly designed as a little wedge to get between the head, the cephalothorax of the tick, and your skin, and to repetitively move against that object. The tick has the option of disembedding itself. It can remove the mouth parts. And if it gets assailed often enough, it will begin to loosen up its mouth parts because it knows that it's a goner if it gets its mouth part sheared off. And so that's where you get that slow, gentle traction. All of this is you get under that head and you gently remove it. And that wheel and flare reaction it literally is a bullseye that starts off right where the tick is biting, and it raises the tick, that swelling raises the tick up off of the surface of the skin. So the itch scratch reflex is ideal for removing a tick that's starting to feed. Well, what about the excoriations, the T cell mediated itch scratch reflexes that result in chunks of flesh being removed? Well, if you can't get that embedded tick out, you do want to fundamentally remove it one way or the other. We know that most cases of Lyme disease, the bacteria is transmitted 24 hours or longer after the tick has been embedded. That's how long it takes a really active T cell to get on the scene and start weakening the skin so that you can remove that chunk of flesh that may have a tick or a mite that is embedded in you. So there's that. In addition, there's this other fascinating study that came out in 2006. It was the suspicion that mast cells, these allergic cells that are involved in immediate type hypersensitivity, really could be problematic for venom allergy. And so some researchers bred a strain of mice that didn't have mast cells, so they couldn't have these histamine mediated reactions. And then they injected them with honeybee venom and snake venom. and the mice died. So in fact, it looked like that, the hypothesis was that these mast cells that have histamine were somehow making the venom reactions worse. But this was really quite startling, that actually the mast cells are probably protecting us from venom. When the venom comes, the mast cells open up. It's not just histamine that they have. There's other things in those granules, some of which may be proteins that help to degrade the venom so that the venom stays localized and doesn't get transmitted throughout the body. This is the best. I was trying to get a photograph of a bee stinging me, but I couldn't get it to sting me. And then finally it stung me, but then it just was kind of gently stinging me. And so this was the best photo I got of that. So sorry, I don't have a better shot of a bee sting. Another demonstration of the value of the itch scratch reflex. Again, I get consulted on a lot of good arthropod bites, stings, and infestation. So here's a consult that I had quite a few years ago. There was a girl with cancer who was undergoing immunotherapy, chemotherapy for cancer. And the oncologist noted that when she gave the patient the chemotherapy, the patient would lose this intensely itchy rash that was all over her body. But then as the chemotherapy washed away over the course of a month, the rash would come back, and then she'd be ready for her next round of chemotherapy. The rash would go away. And it was all over her body, but you could see some of these were little bumps. And it reminded the oncologist of scabies, and said, could this be scabies? And I said, well, that's an easy thing. All you have to do is a skin scrape. You take a little scalpel and you take one of those bumps and you put it under the microscope, and you can see the mites. They'll kind of wave at you, squiggly, kind of cute, frankly, under the microscope. Easy diagnosis. And the oncologist is like, oh gosh, she's got no immune system. So can you do this without scraping the patient's skin? I was like, gosh, I don't know. So I went, I saw the patient, I was thinking about it. Now I did my my residency training in pediatrics before I became an allergist immunologist. I have treated 100 more patients with scabies, and I'm sure that I've had scabies on me plenty of times. And I must have, because while I was handling this patient, I had a wheal and flare reaction on my hand. I was like, wait, what is that? Do I detect a mite that moved from the patient onto me? So I scraped it. I looked under the microscope. Sure enough, there was a little scabies mite waving at me. So again, I didn't have to treat myself for scabies. All I needed was the itch scratch reflex. These very delicate mites are not really great at surviving. Our allergic immune system is pretty good at destroying it. Now, they do have some immune evasion techniques, so I'm not going to recommend you go and deliberately put yourself into contact with scabies infested folks. But in the end, it's be thankful for your allergic immune system. It's very unlikely to cause you harm. Unfortunately for this patient, because of her cancer, she was having her allergic immune system wiped out, which is why the mites were able to go over her entire body in very, very large numbers. We were able to treat her and get rid of her scabies, and ultimately she finished her chemotherapy and went into remission for her cancer. So this is the allergic immune system as a whole, sort of complex pieces that work together that create a lot of misery when it activates inappropriately, but is frankly quite helpful when it acts appropriately. Just some of the players, the eosinophils and basophils, in addition to those mast cells. The neutrophils are really the partners for the Th17 cells that are fighting bacteria. So now, kind of fleshing out this chart a little bit, remember that we said the innate inflammatory responses was pain that got better over days, whereas Th17, which was bacteria, is pain that gets worse over days. Now we're adding to that the itch. So itch from histamine is it comes on really, really quickly, but then gets better over hours. So kind of, rapid, kind of like the innate pain is histamine itch. And very similar to the pain of Th17 cells that got worse over days, the itch of Th2 cell gets worse over days. So these are all really, really helpful pieces of the story to tell you what kind of inflammation it was. And if you know what kind of inflammation it is, it helps you to narrow down what the problem could be. Again, we're taking Th1 responses out there because those are for viruses and things that get inside of your cells, which insects do not get inside of your cells. Unfortunately, as I alluded to, the allergic immune system sometimes gets it terribly, terribly, terribly wrong. Um, just as the other parts of the immune system can cause autoimmune diseases and things like that, the allergic immune system, when it gets wrong with venom in particular, the really scary reaction we see is anaphylaxis. Um, the number of symptoms you can have with anaphylaxis is a little bit overwhelming. In a way, it's one of those things, well, anything could look like anaphylaxis. A quick introduction to the terminology of anaphylaxis, just because I think it's interesting, was that in 1885 is when prophylaxis was first started with Pasteur, vaccinating rabies into dogs to prevent rabies in dogs, ultimately extending to people, and was able to prevent rabies in people, which was great. Learning of these successes, the Prince of Monaco took two young immunologists working with Pasteur out on a yachting trip and said, "Hey, I'd really like it if you could cause prophylaxis for the jellyfish stings, because they are really, really miserable. Could you do that?" And the immunologist's like, "Yeah, the price is right. We'll inoculate anybody with anything." So they started with dog studies and unfortunately killed the dogs in their studies. And this was very perplexing to them. So instead of getting prophylaxis, they got anaphylaxis. Ultimately, more immunologists got involved over the years, leading to, in 1998, the final studies that determined how we can get prophylaxis, really the induction of tolerance um, for allergens. Circling back to the question of what is anaphylaxis, recognizing that any organ system could get involved, we have a working operational definition. So if you get stung by something, um, and you have two organ systems involved, that's basically a definition of anaphylaxis in a patient that's never had a similar reaction before. So this is your step two. Now, if it's something that would be for like a honeybee or a paper wasp or a yellow jacket or a fire ant, the unlikely triggers would be a lacewing gets you. Because those are unlikely triggers, we won't let any two organ systems involved. One of those organ systems has to be the mucocutaneous. And this can't be a point where it's itching. This has to be hives or swelling over over parts of your body distant from the site of inoculation. But the requirement generally to have two organ systems prevents you from overcalling a reaction as an allergic reaction, when in fact you vomited because you were scared because you got stung, or you had an asthma attack because you got stung. But that's anxiety can trigger asthma attacks. So it was an anxiety triggered asthma attack. It wasn't the venom directly that triggered the reaction. So that is our operational definition of anaphylaxis, is you have two organ systems involved. An important caveat there that I just went past is if you already know that this patient is allergic to something and they just lose their blood pressure, that's enough. Now, you don't have to measure a person's blood pressure. If you see somebody who's fainted and you look on their wrist or on their necklace and they have a medical alert bracelet that says that they have had anaphylaxis in the past, you can go and treat that as anaphylaxis using epinephrine. So that is one of the recommendations, is that anybody who's had anaphylaxis have a medical alert bracelet on their, as a necklace or as a bracelet, so that they can get epinephrine as quickly as possible if they're having a reaction. Just to stress the importance of that, there are a series of studies that have been done looking at why some people die from anaphylaxis. Most people don't die from anaphylaxis, which is really, really fortunate. But all of these studies that we have really demonstrate that it is delayed administration of epinephrine autoinjectors, those EpiPens and IVQs that you can inject right into your leg. If you delay that, you increase the risk of death. And if you treat rapidly, it works really well and a person can feel great very, very quickly. So we're trying to just get that word out there that you don't have to be a physician or a nurse or anything. If you see somebody down with a medical alert bracelet and they've got an auto injector on them, which is what we're recommending, you just go ahead and use that. If you haven't been trained to use one, just find somebody who can train you. I'm always happy to talk anybody through it. They're very, very simple devices to use. In the next year or two, we expect that we're not going to have to rely on auto injectors with the needles, and that first we're going to have nose sprays with epinephrine. So that'll decrease the amount of anxiety that bystanders will have to inject the epinephrine into somebody. You just, somebody's having trouble, you whip out your epinephrine nose spray and do a couple squirts into each nostril, and that should treat them effectively. And maybe 2 to 3 years from now, we expect that we're going to have these films that you can, like a little strip, and you can put that under your tongue, and the epinephrine will absorb under the tongue. So we're really looking forward to that because we think that's going to allow for prompt treatment for more patients. Then, if you are allergic to venom, unlike if you're allergic to foods, we have great news for you. All the way back in 1978, this older study was conducted that demonstrated that we can absolutely desensitize people for their venom allergy. So in this group, only one patient of the 19 that went through a desensitization protocol with venom had a systemic allergic reaction when they were restung. And it wasn't a very severe reaction. It was a very mild reaction with that. Whereas, there were 58% of the patients that were stung um, uh, after not getting any immunotherapy, any desensitization, they had a reaction. It's an interesting thing. I actually don't know why, if you have a venom allergy, you don't react to every single time you're stung. So if you have a fire ant allergy, it may be only every other episode of being stung that you have a reaction. Same with honeybees. It won't be every single time that you get stung that you'll have a reaction. But it looks like it is above 50%. The middle is just they were wondering if they could do a whole body extract as opposed to extracting the venom itself. And no, that didn't work particularly. So in my clinic right here, this is a lot of what I do. People who have venom allergy come in, and I put them through an induction protocol to desensitize them. And then they're safe. It's very, very rare. I've never actually had a patient have a reaction after they've been restung after I've desensitized them. So I have to tell them it's certainly possible, but it looks like it's very, very safe and very, very effective to get desensitized. Uh, just the protocol that we use in this clinic here is that you get 10 injections of the venom over about 4 hours. And then we maybe 3 or 4 hours, and then we'll do 1 or 2 hours of observation at the end just to make sure that everything went well for you. And it's one of the very safest things I do in my high-risk allergy clinic. So I always enjoy when venom allergy patients come through here because I don't have to worry too much about them. Now, you are completely desensitized after this half day. So it works really well. You can go and get stung that same day, and you really don't have a risk of having an allergic reaction after that. Unfortunately, your body will develop the allergy back. So you remember back in that picture I showed up at the early part of the slide where you have these plasma cells in your bone marrow that are making these allergic antibodies. So that happens. The desensitization only takes those allergic antibodies off of the mast cells that would release histamine. So it protects you from that. But unfortunately, over the course of 1, 2, 3 months, the IgE, these allergic antibodies, will reaccrue on the mast cells, and now you can have an allergic reaction. So because of that, you do have to keep coming back into clinic and stay on regular shots. There is some debate on how often you have to come in, and we don't have great data. In our clinic, we do it as monthly injections for the first 6 months and ideally 12 months. But after that, we'll space the injections out to every 6 to 8 weeks. And once upon a time, we said you had to do this for the rest of your life, but we've got pretty good data now that you can stop after 5 years. Some research suggests it could be even as early as 3 years. And in those cases, 80% of patients will have a permanent cure from their allergy. Now, I hear you, sometimes you say, well, 80%, that's not great for a life-threatening reaction. I don't know if I'd feel comfortable stopping after 5 years. The consolation there is if you weren't permanently cured, a year or two later, your allergies come back, your next reaction will not be as severe as that first reaction that made you come in to get desensitized in the first place. And so we do feel that it's safe for nearly all of our patients to stop allergy shots after 5 years. There are exceptions. I mean, we have patients that really pretty much died with their reaction, and if it weren't for a bunch of epinephrine, they definitely wouldn't have made it. Their repeat, if you say, well, it may not have been the next reaction won't be quite as bad as the first one, well, it still may be bad enough to kill you. And so for some of our patients, we'll talk them through with that, and if they want to, we'll keep them on the allergy shots for really indefinitely until they feel a little bit more comfortable with coming off. But the vast majority of our patients will stop getting the allergy shots after 5 years. We feel very comfortable with that. All right. Yeah, so I wanted to just circle back to the innate inflammation, because there are a couple of additional factors that can affect innate inflammation. And for this crowd, I thought you might enjoy this sort of lagniappe bit. So the things that are being put into you from the venom or the salivary components in the case of bites, they can do things to you, and those things can be useful in helping to narrow down what it was that might have bitten or stung somebody. So if the bite or sting is just excruciatingly painful, that suggests that there might be these biogenic amines in the venom. And the social Hymenoptera, the social bees, social wasps, social ants, I guess all ants are social, are known for having these biogenic amines that create pain far out of proportion to any actual damage that's done. And so in those cases, you look at the puncture wound of, let's say, a yellow jacket sting, it doesn't actually look all that impressive. I mean, it's a little hole and there's blood in it, but it feels like you got shot by a bullet. And so that's pain out of proportion to any actual injury. That's because the venom components, these biogenic amines, mimic our neurotransmitters. And so the neurological stimuli that's getting transmitted is that there is now catastrophic damage that's taking place in your tissue. You can get similar pain out of proportion to injury with other neurotropic salivary components. The aquatic Heteroptera are kind of known for this. So the belostomatids, the giant water bugs, and the back swimmers and the water crawlers, those Heteroptera, the suborder Heteroptera that live in water, the venom is really very interesting. Having been bitten by a couple myself, it does feel as though somebody had teased apart the sensory neurons and applied an electrical current directly to them. So the venom is clearly having a direct effect on the neurons that create this electrical pain that comes through. So that's very interesting. Many of the insects that are adapted to blood feeding on people will include anesthetics that are effective on people. So it's just really, really interesting. Mosquitoes being the quintessential one, but bed bugs as well. So all of these insects that can bite without being detected. I don't know how many of you have been bitten by, let's say, a bird adapted mosquito, like the big galley nippers and things like that, but they really, really hurt because they don't have anesthetics in their saliva. They're used to being able to go up and just feed on a bird without having any sort of repercussions. People have hands, and so it's easy enough to smack these mosquitoes. You don't love the fact that human adapted mosquitoes have the anesthetic so that you don't know that they're there until your IgE, the histamine mediated reactions, let you know that. But on the other hand, it's quite galling when you get one of these mosquitoes that's adapted to other vertebrates, because they're really quite painful when they try to bite you. And then, of course, anticoagulants, horseflies and deer flies are notorious for that, to the point where it's kind of diagnostic for me. So people will say, I got bitten by something, it flew up and it got me, and then blood was just dripping out of the wound. Well, you should be able to clot that wound. It's not that hard to clot up a wound. Why should you be dripping blood? It's because somebody injected anticoagulant into you. Horseflies and deer flies aren't the only ones. So ceratopogonid flies have an anticoagulant, but they're so tiny, it's just almost like a little bruise rather than the dripping blood that you get with the anticoagulants that the horseflies and deer flies spit into your tissues as they're feeding. So that can be helpful. And then, of course, the really fascinating venom characteristics of some of our favorite arthropods that we have here. The fire ants depicted on the left, a component of their venom, these venom alkaloids, attract neutrophils. Neutrophils are part of the Th17 responses. They're only supposed to come in for bacteria. But because of this very unique venom component with the fire ants, the neutrophils will come in response to venom. It's not helpful. It's sort of accidental. And it's depicted here, these little pustules. It's fair enough that many people say, oh, this looks bacterial. Maybe I need to use an antibiotic. You do not need to use an antibiotic on these. There's no actual bacteria. It's understandable why we use our visual cues to suggest that, yes, this looks like a bacterial infection because it does have neutrophils in it. But this is just a quirky, unique component of the venom. And then on the right, we have really fascinating species of venomous caterpillar. By far the most common are the buck moths that you see there that feast on oak trees in particular. And they also have unique characteristics to their venom. That this is my hand. We're trying to get good pictures of it. So I smacked one. And you can see it does the same wheel and flare reactions like a histamine mediated reaction. Of course, this hurts like crazy. So it's not histamine, but there are other biological substances in the hollow spines of the caterpillars that cause that. We have the other venomous caterpillars, including the pus moth caterpillar, the puss caterpillar, that creates a similar lesions to this, but you'll get sweating on the surface of the skin. And 30 to 120 minutes later, you get aching in the regional lymph nodes for reasons that we don't know. Psychologically, venom from caterpillars can be really alarming, but they are not dangerous. And so you don't actually need to seek medical care. Oftentimes, when you are stung either by the fire ants or the caterpillars or any of these things, really, it creates a psychological alarm. You just feel that something is not right. But the pain, again, is out of proportion to any actual injury that's going on. And so reassurance is really the ideal treatment in these cases. Speaking of the alarm that comes from being stung, a quick aside into the psychology of all of this, because this becomes a big part of what I deal with as well. There is infestation behavior that's programmed into the minds of mammals, been studying in cows and reindeer and other animals. But there are these behavioral changes that happen when people are infested with things, including sugars, ticks, head lice, and more. Really triggers really interesting psychological processes. Allergic patients in general demonstrate these phenotypes, this behavioral differences. So, for example, you're more likely to have panic disorders and anxiety disorders if you have asthma. If you've got nasal allergies, likewise, you're more likely to have these psychological disorders and eczema or atopic dermatitis, stress and depression. So definitely there's a connection between the mind and this part of the immune system. And I'll spare you some of, in the interest of time, some of the reasons why and the experiments done to sort of validate that allergic people who are having venom allergic reactions, et cetera, are in fact more anxious. And move on to the last of these sort of psychological phenomenon. Delusions of parasitosis, misspelled there, is probably the most common of those that people in our field kind of run into. Patients that say, I've got these parasites in me, and you look and you're like, well, that's definitely not a parasite. There's nothing going on there. But that extreme phenotype fits into a broader psychological profile of unexplained dermopathy. So bad things are happening in the skin. There's definitely some like human attentional problem that's making the skin problems worse. And it ultimately stems, whether it's a true delusion or a less severe form, with a belief that the thing that you see or the thing that you feel is due to an external harmful pathogen, that you're blaming something that you're seeing or feeling on a parasite of some type. People will do fungus and worms and all sorts of things that they think are causing their problems. But this is an error in cognition. You are misattributing what you're seeing or feeling to a cause. You've got the wrong cause for the effect. And this can be really, really hard to deal with. But it goes all the way back to, in the case of real insect bites. So it's not always delusions, trying to convince somebody that they've got bed bugs, or trying to convince somebody that their kids' delayed type hypersensitivity reactions are from mosquitoes, when they think that it's from the spiders or something else, they've got this cause rooted in their mind, this belief. And I got to say, it's one of the errors that people will make is they'll think that the patients or the customers are hallucinating. They're not hallucinating. It's a cognitive error. They see the same things you see. They're just calling it by a different name. You might, in the case of actual delusions of parasitosis, they may show you some lint, and you're like, well, yes, that's lint. They say, no, those are parasites. You're seeing the exact same thing, but you're labeling that thing with a different word. You believe it to be a different thing, but you can't make them. You don't sound very credible when you try to convince them that the thing that they see isn't there, because they're not actually hallucinating. It's the cognitive error. Those cases can be really frustrating, and I'll say all the way again, the most extreme end of those are the delusions. Delusions, by definition, are fixed false beliefs. And so if somebody actually has a delusion, that fixed part of the definition means you cannot convince them that they're wrong about the cause of their effects. And it's kind of not even just a waste of time for you to try to engage somebody with delusions of parenthood. It's actually harmful to them. Because you can imagine if you just knew something to be true and everybody keeps telling you that the thing you see doesn't exist, but you know that you see it and you know it to be true, it gets frustrating. And having taken care of a fair number of these patients, they feel really alienated. So I'd go ahead as far as to say, like, just don't engage it. Like, you don't want to lie to people. You say what you see, you define what you define, but I probably wouldn't spend a whole lot of time trying to convince them that a delusion isn't real, because by definition you can't. And if you could, then they wouldn't have that as their diagnosis. In patients where it really is just a cause effect and it's understandable that they would misattribute something, you can acknowledge, like, oh gosh, well, let's start with your symptom. Let's say what you actually have. Sounds like you need to work on this problem, but the problem may not be caused by what you think it's caused by. So we need to circle back to the cause for your effect. But I do validate that whatever is going wrong with you sounds like a pretty awful thing, and we should probably get that taken care of. All right, and with that, I will close and just say, oh, I put my old email address. I've moved over to Ochsner from Tulane. So it's still the John Peard Carlson, but now it's ochsner.org. If anybody cares to be in touch with photographs or specimens or stories, I always enjoy learning from folks along the way. So thank you so much for listening to some of these fun stories that I have in my work. I'm happy to take any questions.
John, thank you so much. That was incredibly interesting. And as it touches on the delusionary parasitosis, for us, it's a almost regular occurrence. We actually had a case today, right? So, you know, obviously, I think your suggestions were excellent. But there seems to be a process, right? These people will call their pest control. They go to the physician. They talk to a pest control company. They go to actually multiple physicians, and then they'll go to a do-it-yourself type pesticide company, and then they end up coming to us. We just don't have a lot of training, but two, where do we send these folks next?
Yeah, that's a great question. So I used to have a clinic specifically to see these patients. Unfortunately, I've gotten so busy, and that was sort of my lowest clinic, because the patients, fortunately, are a little bit rare compared with, like, say, venom allergy. At some point, I really want to start that back up. Since my transition over to Ochsner, I should have a little bit more time. I'm hoping to eventually do that. I'll let you know if I'm
Okay,
able to start seeing those patients again. In
that'd
the
be great.
meantime, again, like having to take care of these folks, they actually are usually pretty smart. Now they're,
Yeah.
they're not always. There are other cognitive defects. So if you have, say, schizophrenia, or that's a different kind of a problem. But usually this is a single fixed false belief. These are functional people who are smart and funny and creative and clever. And I would actually hazard to say that maybe they're even a little brighter than the average, and maybe that's part of the problem. it's tough because you don't want to confront the delusion and tell them that what they're seeing isn't real, but you can't confirm it either. So the best you can do from that standpoint is to say, not that you don't see anything, but rather that you don't see anything harmful.
Right.
There is no pathogen here. There is no pest that we
Right.
would do a control measure for. Um, the understanding of like the human microbiome and the better understanding that we're a complex ecology and that a lot of
Hmm.
the stuff in and around us is not harmful has helped a little bit to just say like,
Okay.
look, there are things that we do pest control for and there's things that we don't do pest control for. There's nothing here that we do the pest control for is probably the best you can do. And then there are management options that physicians can use for these patients. There are medications that you can use, but you got to
Hmm.
be so with patients, you have to be really honest. And so if I'm treating somebody with one of these medications, I need to let them know why I'm using these medications.
That's
And
right.
it's a tricky conversation to have. And I think most of the physicians in our area are not. It's not a skill set
That
that
they
they've
have.
developed. So
Right.
eventually, I'm going to restart that, and I'll let you know.
I think that's a really great, because some of these folks, we've had people that are spraying themselves with pesticides, and we obviously talk about why you don't need to do that. But I'm glad to hear that you're going to move that in that direction for a resource. I'm going to kick it over to Stacia. She's going to go through the chat. It sounds like we have lots of comments and some questions in there.
Great.
Yeah, so the first question is, why do some bites or stings swell up and fill with fluid and some don't? And why do some bites or stings take forever to heal and some don't?
Great question. So the ones that are blistering, like here again on the bottom left, there is some additional priming that the immune system has had that's not normal. And there's a wide variety of reasons why it could be specifically primed. And it could be towards a type of saliva. So, for example, I will, let's say, blister with Aedes albopictus bites, but I won't blister with Culex kinkifaciatus bites, or bed bug bites make me blister, but no mosquito bites do. So there are some people that it's to a genus of insect. Those are probably safer in terms of having underlying medical conditions not be a problem. But then for others, especially where they'll blister with multiple different kinds of insects biting them or stinging them, that's where I worry that there could be a cancer going on. And so for those patients, we do screen them and make sure that there isn't more going on that we need to treat. So that's for the blistering. In terms of how long it takes to go away, there's two sources of injury that has to get healed up. One is if you are injected, let's say, a honeybee. Some honeybee stings are dry, and so there's no real, it's just the innate inflammation. The innate inflammation is, or innate inflammation from a puncture, but other times the honeybee will inject a moderate amount of venom, and other times they inject a whole lot of venom, particularly if you don't get that sting apparatus out, if it's detached and it's pumping all that venom in. So there are actual injury causing peptides that are in there that could be really destructive. So the more venom, the longer it's going to take to heal up. So that's one of the variables. The other of the variables is if you have a T cell response, the T cells injure the skin. I said that in the course of the itching and scratching and the removal of the chunk of flesh as one extreme. But even if you don't remove that chunk of flesh with the scratching, the T cells actually are still injuring the skin where that bite or the sting took place. And so if you've got T cell responses, it's going to take a lot longer and the injury is going to be worse.
Okay, the next question. Can an excessive number of mosquito bites in a short period of time also result in the absence of future reactions?
Yes, that is exactly it. So the more bites you get in total, it doesn't all have to be clumped together. The more total number of bites you get, the less likely you are to have a reaction with the subsequent injection. Again, we don't recommend that because there's West Nile virus out there and things like that. So I will say that as the caveat, we do try to get people to use repellents.
Okay. Perhaps it has already been discussed, But is there an actual allergic dermatitis experience when small arthropods, such as SOCIDs, contact skin? Or is it more likely that the individual complaining of itching is scratching themselves because they might feel the arthropod move on them?
Oh, that's a great question. Yeah. So there is a wide variety of arthropods. I don't know specifically about SOCIDs, but many will cause an irritant dermatitis just from contact. And it's not clear entirely why. For some of the arthropods, it's a minority of people coming into contact with them, caterpillars in particular, that will be irritated by them. Whereas others, like the venomous caterpillars, everybody who comes into contact with them will have a reaction. There are moths, likewise, that will do that. But yeah, it's very very interesting. But that contact dermatitis is definitely a phenomenon that's out there. But SOCIDs is the first one I've heard about SOCIDs, so I'm interested to hear more.
Okay, and then I also have a question.
Hmm.
About 20 years ago, I was stung on campus by a bee and had a severe reaction where I was hospitalized. And I heard you talk about how you can kind of treat those reactions and maybe desensitize people. For me, I've just always carried an EpiPen. Uh, what are your thoughts versus should people be thinking about that treatment you talked about, or is the EpiPen enough, especially for someone who had a severe reaction?
Yeah, no, unfortunately, it's not enough. So no, the EpiPens are not perfect, and they don't always save people's lives. So there are plenty of cases where people died despite using their epinephrine, because if you have a severe reaction, those severe reactions can come on incredibly quickly. It takes about 15 minutes for the epinephrine to get absorbed after using it. And if you've already lost it, the epinephrine stops the reaction from getting worse, but it doesn't make you better. Your own body has to compensate. But if you're in the middle of having shock or your vocal cords are swelling, you're not able to breathe, any of these sorts of things, it's kind of too late. You still use the epinephrine, and you're hoping that it gets in there in time that you can compensate for it. But no, unfortunately, the recommendation is for anybody who's had these severe reactions, that they undergo desensitization, because those plasma cells in the bone marrow, they do live for decades and decades and decades. So that is in the guidelines that everyone should be desensitized.
Okay, thank you. The next
Sorry.
question is, hi, yeah, it's not what I wanted to hear. Um, which repellents work best, or do some repellents cause adverse reactions?
The Okay, so first of all, the the best repellents are the DEETs. There are others that work, but probably not quite as well. Um, Also, the permethrin impregnated clothing are amazing, super super good. I mean, there are mosquitoes and so many other things will bite through clothing. Those are really lovely products, either to purchase them pre-treated or to buy the spray on your own. I love them. It's such a great way. The repellents that you put on are a little difficult in southern Louisiana, where you sweat the minute you go outside. I mean, right now is a lovely time of year, but we're not that far off. And so the DEET and other things, that they don't stay on quite as well. But yeah, so that's the number one recommendation, is that we use a DEET containing product, or if you don't like DEET for whatever reason. Now, DEET can be irritating, more to some people, less to others, and so you don't need to go to the highest concentrations of DEET. You can get the off family, is not super potent, but it will actually work pretty well. You might want to carry it with you to reapply. Again, as you sweat it off, you may need to reapply. And then if the rest of you is covered with permethrin impregnated clothing, and you're using the long sleeves and pants and stuff like that, works really, really well.
What type of physician would be best to refer customers towards that are having reactions to possible insect bites?
Allergists are the ones that specialize in that. I will say, even among allergists, insect allergy is a niche specialty. So, there's like 10 of us across the country. We are sort of known for having a center here, just because that's my, bachelor's degree through PhD, and this is what I've done all these years. So we have that center here at Ochsner that I established about 9 years ago. So they're always welcome to come by the Ochsner Allergy Clinic. I just like transferred my employment over to Ochsner, but even before that, I was contracted from Tulane over to Ochsner basically to establish all of this center. So I know that this is patting myself on the shoulder, but it's really well done. And I don't know of a clinic that does as good of a job as what we do anywhere in the country.
Is over 25% DEET recommended?
You don't need to. You really don't need to. Dr. Regal probably would be a better person to ask about all of this. And I treat adults and kids, but more kids than adults come into my clinic. And with that thinner skin, we do worry about irritation. So I'll usually do the, 12.5% is my typical starting point.
The only thing I would add to that is make sure that you read the label on those products, right? Because it's much like sunscreen. You actually have to reapply after a certain period of time. So, and again, if, we have 2 employees that have DEET sensitivity, so they end up using Picardin or some other repellent that's recommended by CDC and always registered by the EPA, right? So it's important.
Yay. Thank you for that.
Okay, just to make sure I understand, the bites of recluse species do not cause the necrotic lesions and death. It usually is other infections like MRSA. Is this the same for Black widow species as well?
So yes, just again to verify, the recluse bites, the horror stories you hear are mostly not true. I'm not saying that there's not a 1 in a million chance of some horrible thing happen, but there's got to be something wrong with your immune system if you can't break down the venom components. If you go to a state like Arkansas that actually has a bunch of brown recluse spiders, they have a lot of bites they treat, and it's just these little purple bumps, and that is what your typical recluse bite is. If you see a big ulcerative lesion, it's much more likely to be some other problem, and that's really important because, frankly, some of those other problems like melanoma and the cancers, they're really bad. And so dermatologists, if you've got a bad lesion like that, a dermatologist needs to be involved. They need to biopsy it. They need to figure out what's going on, particularly if you're having recurrent lesions like this. You want to make sure that you're being appropriately diagnosed and managed. The widow spiders are a little different. They have a very interesting neurological toxin. It works directly on the neurons. And so most of the widow bites are also not particularly problematic. Maybe you get a little pain and or numbness at the site of the bite. The only time you get into trouble with the widow spiders is if they put in a lot of venom, and so this neurological toxic venom goes all over, and you sort of get the rigidness of your stomach, cramping and pain in there. There you can definitely run into some significant problems. And so if you start feeling that, the abdominal cramps and stuff like that after a widow bite, you definitely should go into an emergency department for treatment.
Okay, thank you. That's all the questions in the chat.
Well, wonderful. Thank you all so much. And I'm so fun to be able to do this by Zoom so I can show you my clinic right here where we do a lot of these consultations that we've been talking about.
Oh, we have one last question.
Yes.
Have you had any experience with spider bites from Australia?
No, I talk to the Australians sometimes. They've got a whole other world of venom over there. Their ants are different. They actually do have some of the imported fire ants that we have, but they've got other kinds of crazy ants, jack jumper ants. They've got spiders. They've got poisonous mammals that we don't have. I mean, it's a whole other world over there. They're interesting to talk to, though, but their venom experts are in a very different area than our venom experts.
Okay, that's the last question.
All right. Well, thanks, everybody.
Thank you so much. We appreciate your time.
I appreciate you.
And thanks
as well.
everybody for attending. Great. Thanks. Bye.